Thank you for the introduction. Thank you for the invitation. You put me in this important symposium, but actually my talk will be very simple and friendly. I just would like to share with you something interesting I saw in the last couple of years. Yeah. As requested, I'm going to show you the end of the presentation. So I'm finished, and that's all. Hello? I had some problem. This is the end of the presentation. Okay, let's do it this way. Okay. As requested the presentation, as requested my photo, this is me in my office. What you see on my shoulder, behind my shoulder, are all the gifts I received from Bangladesh. Okay? So I probably I have to buy another shelter to put my things. Is it working now? Okay, okay. And another photo is this. Probably there is a chair, you cannot see it, but this is me in Estro 2025 in Vienna with another gift from Bangladesh. I was proudly wearing the jacket I received from you last year because I lost my jacket in the airport. So what we are talking about, generally speaking, what we do comes from guidelines, and guidelines come from randomized studies. You know, randomized studies, they take a lot of time, they are expensive, and at the end they give us only one answer, the one related to the primary endpoint. So we do a long study, at the end we know something. Something new to integrate this pathway is the use of another system. The system is collect large database with a great number of patients and collect a lot of data, prospectively or retrospectively. Then at this point we have the possibility to analyze them by new systems that give us the possibility to personalize the treatment in these patients. And these systems today are based on artificial intelligence. And the interesting part I will show you is that sometimes the results of our analysis are totally unpredictable. Okay? So we always wanted to have predictive model to tailor the treatment of our patients based on their characteristics. And the traditional way was the use of nomograms, for example. I'm sure you know the nomograms, how they work. Here you have the characteristics of the patients. Okay, it's not working there. Okay, you have the characteristic of the patients here. Even this is not visible, I'm sorry. On the left, you see the characteristics of the patients. These characteristics can have different values. So, for example, we have a patient with a PT2 stage, which means, based on the line on top, minus 0.1. Then end stage of 1, which means plus 0.6. Then we continue with all other characteristics of the patient, of the tumor, and of the therapy. In this way, we reach a sum, you see, at the end, plus 0.7. You put this value on this line, and automatically you know that the probability of local recurrence in this patient is 27% around. Okay? Which can be interesting or not. What is interesting is that we can... Oh, thank you. Thank you so much. The interesting part is that we can change this parameter. I can see what's happening in my patient if in spite of using 50 Gray, I use 55 or 45. Here I decide not to give adjuvant chemotherapy. But what happens if I decide to give adjuvant chemotherapy? And this is a dynamic way to use these nomograms. So, for example, the 5-year probability of death in a patient with a PT3N2 rectal cancer without chemo is 76%, but with chemo is less and less. So in this particular patient, probably we are ready to prescribe chemo. And what happened in a patient with a complete pathological response? In this case, the difference between no chemo and chemo is only 4%. So in this case, probably we will discuss with the patient. We are talking about a very small difference. This is nice. Isn't it nice? Say yes. Say yes. Looks nice, but it doesn't work. These models are not reliable. You know why? The reason is this. We do calculation with a simple sum. And medicine is complicated. Medicine is biology. Medicine we cannot predict outcome just with a sum. And in fact, the results of this calculation are fake. Because what we know is that adjuvant chemotherapy is more effective in this group population, not in this group population. So nomograms, we have 1,000 publications about nomograms, but their results are not reliable. So I show you a couple of examples of what I mean about the new systems. This is a study we performed some years ago. We wanted to know, are we Italian radiation oncologists able to treat with the right analgesic our patients? Unfortunately, the answer was no, because 45% of patients with pain in Italy are not treated well. Then, using standard statistical systems, we try to understand who are the patients who are treated badly, and the answer was this. So inadequate pain management is in young patients treated with curative radiotherapy, the fit patients, patients where pain is not coming from the cancer, but from some maybe arthrosis, some benign condition, and in patients without metastasis. What is your interpretation of this list? I'm not sure about breast cancer, why breast cancer patients are treated badly, but the overall picture is if the patient looks good, is young, his performance status is good, his prognosis is good, because has no metastasis, is treated with curative radiotherapy. In this case, the doctor is more interested about the cure, about the outcome. Is less interested about the pain. That was our interpretation. But then we try to repeat the same analysis with some new statistical method. Very, very briefly, what's Lasso? It's a kind of multivariable analysis, able to select from a large number of data the parameters which are really important for a specific outcome. Then CART is a decision tree. It's something that takes this parameter, the important ones, and put them in a hierarchy, organize them. I think it's not clear. I show you the result of our second analysis. Okay, now this is the picture. Now, as I mentioned, 46% of patients are inadequate pain relief. But what is the most important parameter? Is the nature of pain. Non-cancer pain, 3 out of 4 patients are not treated, while the percentage is lower if the pain comes from cancer. Then it's in this group that the aim of treatment is important, because in cancer patients, if the treatment is for palliation, the percentage of inadequate management is lower. And it's in this group that echo score is important. This is the group with the best treatment of pain. Cancer patient treated for palliation with high performance status, bad performance status. On the other side, we have another hierarchy. Non-cancer pain, for some strange reason, breast cancer patients are treated badly, worse than other cancers, especially the younger one. These are the worst treated patients, patients with non-cancer pain, breast cancer, and younger age. So now we have a more informative picture. And we were particularly interested about this group, about the results in this group. And we saw something really astonishing. We are talking about patients with non-cancer pain. The pain is not coming from cancer. What we saw, what is the parameter important, is the type of cancer. How is it possible that non-cancer pain depends by the type of cancer? With the worst results with breast cancer, better results in GI cancer, better results in head and neck cancer. A situation like this is really informative. You also see that the situation is worse in southern Italy compared to North Italy. It's more informative, and it's particularly tiring because you have to do a lot of effort to understand these results. Because I cannot believe that a medical oncologist treating breast cancer is worse than a head and neck oncologist. It's difficult. So we had to study, reading. And at the end, our interpretation was breast cancer patients, almost in Italy, they are very resilient. They are strong. They feel supported. They have psychological support. So for them, pain is less important, especially when they are young. Okay? And then South Italy and North Italy. What is this difference? The difference is that South Italy is poorer compared to the North. But the doctors are not worse than the one of the North. So why this difference? And what we found is that patients in south of Italy have a different psychology compared to the one of the north. Why? South is poor. Patients have social problems, have economical problems, they have a cancer, so they don't put all attention to their pain. They are not ready to report their pain to doctors. There are other things more important than some pain not coming from cancer. And my final example is this, again, interesting. Was a study not particularly important. We wanted to predict acute toxicity in patients treated with salvage radiotherapy, prostate cancer, salvage radiotherapy. Which factors are predicting toxicity? What do you think? Which factor can predict toxicity in radiotherapy or prostate cancer? Is it the dose, the margins, maybe the radiation of the lymph nodes, maybe the comorbidities? The results for us were very astonishing because the most important parameter correlated to toxicity is surgery, is the kind of surgery. Patients treated with open prostatectomy have more than double toxicity compared to patients treated with laparoscopy or robotic surgery. Okay? Then in these patients, only in this patient, the margins is relevant, and only in patients with a small margin is important another parameter related to surgery, which is the number of resected nodes. Okay? While in this group of patients is important the dose. And in low dose is important hormonal therapy. In high dose are important comorbidities. So we have very complex pictures of what is happening. This is gastrointestinal toxicity, this is genitourinary toxicity. Why these differences about surgery? I don't have the time to explain to you because we had to think and think and think and think and study. And the editor of the journal asked us to publish a second paper just to explain our interpretation of these results. And with this, I have finished. I show you something that surprised me. This new system of analysis can give us interesting, not predictable results. And this probably will help us in tailoring the treatment better compared to the old nomograms, and at the end of the day, to improve the outcome of our patients. Thank you very much.